Welcome to the Next Orbit podcast, where connecting healthcare's data is the next frontier. We take you inside conversations with policymakers, healthcare leaders, disruptors, and visionaries who are pushing boundaries in a system that resists change. This is your launchpad. Here is your host, Ben Wade.
Hi, and welcome to another episode of the Next Orbit podcast. Joining us today is a leader at the forefront of digital transformation in one of the country's most complex healthcare ecosystems. As the executive director of digital health at Stanford, she oversees the deployment and strategy of technology that bridges the gap between AI and frontline clinical operations, with a focus on proactive governance and the engineering of truly integrated digital care models. She recently co-authored an article on the framework for using AI to drive care model transformation, building cars rather than faster horses. With that, please help me in welcoming Leah Rosengaus to the show. Leah, thank you for being here.
Thanks, Leah.
Ben, Mike, great to be with you both.
So, Leah, the title of your article was really a tip of the hat to a famous analogy by Henry Ford. Can you explain the faster horse analogy in the context of healthcare, and maybe answering my own question here a little bit, but why is bolting on new technology or AI tools to an existing workflow the equivalent of just trying to breed a faster horse?
Yeah, absolutely. This is a quote that I think there's maybe some debate as to whether Henry Ford, actually said this or not, but the message behind it rings true, which is, if we asked folks at, the point at which automobiles were first invented, what they wanted, they would have said they wanted faster horses, because that's what was known. And, that is sort of the stretch of the imagination at that time. And the same is true in healthcare. We've been doing things a certain way for so long that we think a lot about how to optimize, how to make the horse go faster, but it's a whole different exercise to consider how to reimagine the entire care model. And so that's really what our team at Stanford thinks a lot about. Not just how can we solve the immediate problems of the health system today, but what does the future care model look like? What is that AI and digitally enabled care model of the future, and how can we start building blocks towards it today? So that's really, kind of the center of what we do. We use this as a rallying flag to help us think about, is what we're working on truly transformation, or are we, simply cranking the wheel a little bit faster than we did last time? And maybe the last thing, Ben, I'll mention around this is there's a lot of value to optimization work. That is your near-term, high-value activity. And in fact, the longer-term future work, if you think about the Horizons model, that Horizon 3 innovation work might not create extreme value from day one. It's a longer runway to get there. Our COO, Rick Shumway, likes to say, we have to do the tomorrow work today. And that is, that experimentation in Horizon 3, building towards the car so that as market forces shift, we're really ready to respond to it.
That's great.
Yeah.
Do you mind if I jumped in for a second, Ben, on this one? Because I got a little bit to say here, if that's all right.
Go right ahead, Mike.
Yeah, so I guess, Leah, one of the things that intrigued me about this is when you talk about kind of doing the tomorrow work today, one of the things that we've really encountered is that we've been working with customers and also exploring how to change our own internally, like operating model for the way that we do things and get things done, and figuring out how to use, the LLM, the models that are available today, is recognizing that it depends a lot on the quality of the data that feeds that model, whether that's the training data or the data that's provided, to help in context for something you're trying to do, or the way that you prompt it. And as I've been thinking about that, and particularly when you talked about improving, like doing the not just the innovative work, but also the work to improve things, that it seems to me that there's a way to marry those things together as you're looking at your data. Like the data itself is an area where you can focus on near-term improvements that would turn out to be investments in that longer, more transformative arc. Have you found that to be the case, or is that something that you guys are also observing, is that data is kind of a foundational element of this new world that everybody is moving into?
Yeah, I mean, certainly when it comes to the AI-enabled care models, garbage in, garbage out is still very true.
Right.
I'm sure you see that, Mike, in the
100%.
work that you all are doing at Leap Orbit with your clients. Um, I also think there's opportunities to leverage new data that was previously unharnessable in healthcare. And an example of that, you know, uh, is actually I think a lot about the telehealth space and how can we use AI to make telehealth more scalable and sustainable. It's something our team has spent, the last 5 years since the pandemic really building out for the health system. And one of the things that's unique about those interactions is that for the first time, everything about the interaction is data, including the video, that feed that's coming through, the audio that's coming through, even the natural language that's in, a clinical note, the PDFs that are in the media tab of our electronic medical record. These things have been there, but they've sort of been unusable for analytics without a lot of lift and cleanup and extraction. And so I think AI and LLMs represent an opportunity to use that data and make it operationally and clinically useful in ways that we just haven't been able to unlock in the past. Maybe the last thing I would just mention there is our data science team at Stanford, and I think this is going to be true of folks that are building the infrastructure at health systems nationwide, have put a lot of effort into the data lake and the pipes that underpin anything that we would build, kind of on top from an intelligence, an application, or a workflow standpoint. And you really, I can't imagine how you would actually build out the rest of the house if you don't have, that strong data foundation to develop and train your models on. I'm curious, Mike, when you work with your clients, how do you advise them around that? Like, do you start with the data that they have and you develop from there? Do you, work with them first to try to hook up their data so they've got access to it all? What are you seeing in market?
So that's a good question. One of the things that I would say there, we do a lot of work at the interoperability level, excuse me, at the interoperability level. And so we usually do start with their data, but also how can we connect data? And to your point, when you talk about data lakes, a big part of what we do is driving those connections and getting the data and then getting that modeling done in the data lake in the appropriate, for the appropriate level, because not everything needs to be modeled all the way out. It depends on what you're using it for and how much of that kind of roughness is useful to remain in there. Kind of to your point, sometimes what we think of as because of the tools of the past as things that have to be cleansed or removed can now sometimes be interpreted in different ways and understood differently. Not that you don't care about that level of quality any longer, but rather that it depends on the use case and what you want to learn from the data. So those are some of the kinds of conversations we have. Another big thing for us is standards, continues to be standards. And I think I don't see that going away. So that is something that you'll hear us say when we go in, because we do have some clients, depending on how close they are to the work on the ground when it comes to AI, they may believe that it is somewhat like a super smart human being that you can just throw stuff at it and it will figure it out. And in some cases that there's some truth to that. But when it comes to, I guess what I'd say, you said garbage in, garbage out. Most of these models, unless they are proprietary or built special case, have been trained on a huge corpus, but it's a general corpus. And so what they tend to do is average out in some way to some kind of acceptable median answer or response to what you're asking for. And I bring that up to say that because of that, you still need to think about how to get the right data in and get it structured in a way that makes sense to the kinds of questions you're going to be answering and that you want the model to answer in the long term. Because if you give it, it can navigate between different interpretations of what, a patient, something about like, is this M for male or female for female? That doesn't matter so much. That can be worked out pretty easily nowadays with that. But do you have the data you need? Is the context correct? Is the model and the things that are connected under there, are they connecting in the way that you need them to answer the kinds of questions that you're going to need to answer? That becomes more important. And so those are where I think standards also are going to need to go, that we're going to have to move away from, not that code sets and value sets won't be important, but that they'll be less important because they can be handled automatically. And it'll be more important to say, how are we organizing the larger model of how things should work, so that when we ask questions or we ask for action, we get the right responses that are moving more to a transformative space. And that probably sounds kind of like gobbledygook to somebody who's not in the weeds on this, but it's essential to be able to reach that. Like, we can't imagine what the future looks like without first starting to reimagine those models. Mm-hmm. And then move away from having to maintain the nuts and bolts of those models, let the AI do some of that work. But that will then open up new horizons where we need to rethink the models again, and it'll be kind of iterative in my mind. So I'll leave it at that. Hopefully that's a helpful answer, but that's kind of the answer as I see it right now. And as we've been talking to people, like, how can you apply what you know today to move yourself a step closer to what you're going to need?
Mm-hmm. Something you said there, Mike, really resonated with me, which is, there's only so much value that you'll get out of applying emerging technology to an existing process or data set that, is flawed or has inefficiencies. We had a very similar journey when it came to the adoption of digital health and virtual care. Since the pandemic, health systems were under so much pressure that we engaged in this very skeuomorphic exercise where we essentially digitized a lot of the way that care was working in person in clinics. And that works to an extent. I mean, we've seen an incredible adoption of that care modality, but we didn't fully reimagine the entire care model itself in a virtual context. And sometimes I think when we do that, when we apply emerging tech to an older, inefficient process, it can actually be even a little bit more frictionful than the original experience, which we'd spent, decades designing what an in-person clinic flow should look like. And that can hamper adoption or effectiveness of the new, digitally enabled care model. And so I think we have this great opportunity now to sort of go back in and reimagine what that can look like from the ground up. This is a lot of what we talk about in that paper of, if you're just applying technology in one of the layers of the care model stack, you might see some improvement, but you won't see total transformation. We really think about 4 components of what it takes to develop a digitally enabled care model. The first is the knowledge layer, where taking the healthcare context, the clinical expertise truly, lives and lies, those standards, the evidence-based guidelines, that knowledge layer that's informing the practice overall. On top of that, you have the intelligence layer, which is, where your AI and your LLMs will live, and moving us into a world where we can harness all of the data and knowledge that's in that foundational layer. The next layer on top of that is the application layer, which is the layer that the end users, clinicians, care team members are actually interacting with. That's your UI, and it's incredibly important to get that right in order to promote adoption. And then the layer on top of that is actually not even really technology based, it's the workflow layer. That's the care model itself. How are the workforce roles changing? Is the clinical service itself changing? The actual operations around it. And so if you really want to see transformation, I think you got to address all four of those layers. Thinking about them in a modular way, though, can allow you to take some steps in the right direction towards, what that future vision looks like. And I'm happy to wax poetic on examples of how we've applied that in some of our care models at Stanford. But fundamentally, I think that's the challenge we've put forward to the industry, is to think about, if you just deploy the AI on its own, you're not going to see the full value. You've got to put in the effort around the transformation through, all four of those layers, from knowledge all the way to the workflow itself.
Leah, thank you for taking us through the 4 layers of the framework. I guess, and I'll include a link to your article, so it can be referenced by anybody listening. But it's a modular architecture that you propose in your paper. How does this allow health systems to swap out the engine, if you will, as technology improves, without rebuilding the entire care model that you've developed?
Yeah, certainly. And I want to give a shout out to Dr. Ron Lee and our Stanford Emerging Applications Lab at Stanford that has put a lot of work into the thinking of this framework. I think that what we're really working towards is alignment around the idea that you can do work within the knowledge layer. Maybe I'll use our e-consults program as an example. This is a service we talk about a lot that is essentially enabling provider to provider consults that are asynchronous and written through the electronic medical record. Really important for our access strategy. These consults can, mitigate the need for a specialty referral. They save patients and providers a lot of time and effort, and can get the care and the answers patients need much faster than waiting for a specialty clinic visit. So from a care model standpoint, that's a really important area for us, where we've pretty much addressed within the confines of what an electronic medical record can do, jerry-rigging that to enable a workflow that allows us to do these e-consults. And we've done work at the clinician level to educate and train and adopt. And we actually have about 120 condition-specific templates that inform providers when you're consulting on anemia as compared to a lesion of concern. These are the labs, tests, imaging, information that's needed in order for a specialist to appropriately opine on your case. So all of that has sort of been digitized, and you can imagine how those things are folding into that stack of the digitally enabled framework that we talked about, right? The knowledge layer are those, e-consult templates. The intelligence layer, which I'll talk about in a second, is how you can sort of supercharge this model using emerging technology. The application layer is inside of the electronic medical record, where providers are interacting with the e-consult itself. And the workflow layer is really, this idea of moving care from a traditional clinic visit to this asynchronous modality, moving it from provider to patient to provider, so that we can really make that specialty care more scalable and sustainable across the system. So you can do work, and this gets back to your question, Ben, of, how can you start to swap things out and play with the puzzle pieces to get where you want to go? You can do work to optimize your knowledge layer. We've certainly done a lot of template development work. You can do work to optimize the workflow. It doesn't all have to happen at exactly the same pace. So we spent the last 5 years developing this e-consult service. It's been incredibly successful for the health system. It's working really well for patients. And now with the emergence of LLMs, we've developed that intelligence layer, which we actually didn't even have before, to be able to harness all of our data, the context from the electronic medical record, curate the e-consult on behalf of the provider, and actually help surface the relevant clinical data to the specialist, and even support them in some of their initial draft response. There's still always a human in the loop, But the idea is to take these e-consult interactions down, from what could be pretty complex and involving a ton of chart review to a really efficient interaction. And so that's been, kind of the big innovation for us, is this work at the intelligence layer to bring AI and LLMs into the process for our e-consult workflows. And so that's just an example, Ben, of, where I think we didn't develop all 4 layers of the model at the same speed or at the same time, and that's okay. But we should be thinking about all 4 of those critically, so that we keep an eye towards the future vision, even as we're, developing and solving for, the bits and widgets and improvements that we need to make today.
So that's interesting. It's also I think it echoes some things that we've observed as well. We're working on some behavioral health pilots. And when I say working on, we're more supporting them, but we're involved in observing what they're doing and how they're doing that work. And one of them is it's concerned with high risk transitions of care. So basically making sure that the connections are made between like a crisis center and an outpatient center for somebody who's gone through a mental health crisis. And so what they focused on and what they are focusing on, it's not done yet, and we're interested in seeing how it goes, but it echoes what you said about your own experience, is that they first focused on getting their workflow figured out initially, and then making sure that they had privacy governed, standardized data that was well organized for their intent. And at the end of all of that, they're planning to layer on the AI to help support that transition and make it kind of do that handshake more effectively, as you were describing, make it easier for the referring provider and the receiving provider. And so we'll be curious to see what we learn from that. But it's interesting to me because it does echo some of the things that you were saying. And so we can see that happening in other spaces as well in the overall healthcare continuum.
Yeah, so Leah, you gave us a little bit of detail on the framework, and I see that as the North Star, if you will. But I'd like to pivot the conversation briefly to the reality that's facing many health systems today, who are really just trying to keep their horses fed. You authored another article, or helped author another article, I believe it was 5 no regrets moves that health systems can make today to get ready for this digital transformation. How are systems that are currently resource constrained or feeling overwhelmed, how are they able to make certain moves today that what you would call no regrets, and what constitutes a no regret move exactly?
Yeah, I mean, it's a great question, Ben. And maybe I can start with just a little bit of the context. If we take a step back and we think about what health systems and providers are facing in market today, there are many headwinds that make the existing system, challenging to sustain. There's also some tailwinds that are sort of helping us with transformation. So maybe we can talk about both of those. But truly, the reality is that health systems are largely over capacity nationally. There has been an absolute influx of demand since the pandemic that originally we thought was just, pent up demand from patients who didn't seek care, and we're now sort of back in the system. But we actually never saw that demand let up. So our hospitals are very full. Our EDs are regularly running over capacity, and our ambulatory clinics have long wait queues because the number of folks who want to get in, especially for specialty care, are very lengthy and getting lengthier. And this is a problem across the nation. So that capacity and access issue is front of mind for providers of how can we make sure we're getting people the care that they need. Burnout is a problem. Sometimes we don't acknowledge the complexity that came with the transition to electronic medical records, the trauma that our providers and care teams have felt through what they went through in the pandemic, the pressures of increasing efficiency, engagement with payers and insurance. There's a lot that providers contend with when what they really got into this business for was to help the patient and focus on the patient and their clinical needs. So burnout is something that we think a lot about. And costs and prices are high. Even areas around supply chain for health systems, the cost of goods and services is going up. And there's pressure from the top, from insurance and the federal government, to reduce the total cost of care. So you have providers and health systems that are sort of stuck in the middle, trying to figure out how to contend with those two headwinds. So they're very real challenges. I would add to that, like competition from incumbents. There's been a lot of new market entrants who didn't exist before. We can talk about that maybe a little bit later around partnerships. Sites of care are shifting. Site neutral payments are a big potential issue for hospitals as we move from inpatient care to the ambulatory setting, and now even pushing care into the home. And then of course recent reimbursement cuts that are a major challenge. So in the context of all of that, how do you create the brain space, the resources to focus on innovation? That's actually really tough to do. So dreaming about the car and taking a step back towards that, cars versus faster horses analogy is great, but not always easy to achieve. And so the way we think about that is, where can we find opportunities and problems that the health system needs to solve today as our testing ground for some of these future digitally enabled care models? We may move the needle slightly, but we're learning, we're developing, we're growing in that space such that when we're ready for scale, we can achieve that in what we believe the future care model to be. One quick example I'll give around that is actually even the way we approached telehealth before the pandemic, right? We were, those of us who have been working in the industry a long time in virtual care were evangelizing telehealth for many, many years before the pandemic. And it was very difficult to get that adoption going because the reimbursement structures didn't support it. Providers and patients hadn't really tried this before, but we found the pockets, we kept those pilots going such that when the pandemic hit, we were able to rapidly respond and complete a scaling exercise that ended up transforming 70% of our ambulatory practice to virtual almost overnight, rather than what would have been a net new implementation where we had to create everything from the ground up, design, what would our education and communication look like? What would our workflows look like? What would our technology platform even look like? We had those pieces in place. And so that, I think, is an experience that really helped us respond in the ways that we needed to and show up for our patients during the pandemic crisis, and is still applicable now as we think about what an AI-enabled care model looks like. Where can we test those models in the system today to solve some of our burning access and capacity issues, start moving the needle on that so we get the buy-in from clinicians and operations to try it, and then when we're ready, because the market has finally shifted to the point where we must change our entire care model, we're ready, we can scale that out.
Where are some of those areas that you're looking at? When you say that, it's interesting because I think that makes a lot of sense. And I know, on our side internally, we're doing kind of the same thing. I'm sure you're aware of that. But the for decision makers who are trying to decide, what to do, some of the things, I think ambient AI is a big one right now, and these kinds of things we were just talking about with making it easier for the provider to just review and approve kind of a referral, et cetera. Those are obviously high impact and important right now because of what you're talking about with the burnout with providers. As you look to the future, are there other areas that you're looking into, or where you'd say, hey, you might want to invest a little bit of effort here from kind of a leadership perspective to be prepared for where this may go?
Yeah, it's interesting because I even think of ambient AI as a little bit of a skeuomorphic example. we actually we're making the horse go faster by transitioning the
Totally fair.
documentation burden from the provider and automating that, right? But we didn't fundamentally change the way a clinic visit works or the way a video visit works in order to implement ambient documentation or ambient scribe. But it's a great example of a huge amount of value that's getting generated very quickly from that exercise. I think the thought leadership and the mental challenge is now, well, with the opportunity that AI represents, how might we fundamentally change the care model to achieve some of our goals around broader reach, broader access, increased personalization to care, and a more seamless care experience? So, if we think about, AI as care team member, versus AI as tool to automate something that we're already doing. That's, I think, the difference between like where are we fundamentally changing the care model itself. There are some really interesting emerging examples that are maybe not ready for prime time yet, but I think represent what care could look like in the future, where agentic AI and these systems are supporting smart triage and navigation through the health system, even supporting medication management, titration of a medication that's based on a health plan, that's a care plan that's set by your provider, but which could be executed safely by an agent, with appropriate guardrails. That starts to imagine, whether AI can help us in the way care navigators have helped us, can help us in the way clinical care team members have helped us, but which they're, kind of simpler, smaller tasks that our clinicians and operators simply don't have time to do at the volume and scale that's being asked of them. So again, this doesn't come back to, AI replacing care team member, but how can it be your assistant? How can it help augment the care and the experience for the patient so that our human resources can focus on truly the things that only they can do?
That makes me think of something, and I'm just throwing this out here as a thought experiment, not as something, maybe somebody's doing it. I doubt it, because usually I think of dumb things when I think of these kinds of first passes. But when I earlier in my life, I had to wear a Holter monitor for my heart, and they wanted to kind of see what was going on. And I think that, there's a lot of wearables now, and that's why I was thinking about that example. And to your point about AI becoming like a member of the care team and not just automation, it would have been, I think, in some ways very helpful, particularly at that period of my life when I had some anxiety about like my heart. That's why I was having to have this study done. If there had been, if that had also been enabled with AI, and that if something did behave weirdly, that it could notify me or notify my provider that, hey, there's something going on here. Here's what I recommend. And again, that's probably still a little too stepwise compared to the kind of care transformation I think you're aiming towards when you're with your examples. But it makes me think about how those things are going to start coming together in ways that we haven't considered, and that people who are smarter than I am will come up with a better example and implement that better example than what I just described. So I don't know. Interesting to me.
I actually think it's a great example, Mike. I mean, I've been working in kind of digital health and virtual care models for so many years, and wearables and remote patient monitoring are some of the highest overhead models to deploy. There's so much excitement around them because the types of data you can get are, net new data that we didn't use before. We used to just take your vital signs and, check your imaging, do your EKG when you come in. So the idea that we could get all of that information from home and that we could do it between visits and provide between visit care so that your healthcare experience is not every 6 months I have this, spark and something big changes in my care plan, but rather that we can be responsive and walk the journey together. I think there's so much to that that's so appealing. The problem is that all of those are net new care interactions. And we're talking about a health system that's already access constrained. We're not replacing a clinic visit with a video visit. we're talking about all net new data that now has to be monitored and triaged and understood and draw insights from it. And so how could we actually achieve that type of transformation without AI? I think wearables and remote patient monitoring are actually ripe for disruption with AI to help us with smart alerting, so that you as a patient or your care team is not just getting an alert every time something is out of range, but rather that it understands what your normal range is and can articulate when something is trending, up or down, and truly needs to be addressed. There's also a component of initial monitoring and understanding, was this alert real? Most alerts that occur are, I took my blood pressure and my legs were crossed. And so let's take that again and make sure that, this alert is actually a problem, and that validation, or it's tech support. We're now deploying these things into the home. People have questions about how it works and, how to fix things that they're running into. That's very difficult to staff with, you almost need like a full dedicated team of people that's just doing RPM, and most health systems don't have that. And so this technology doesn't get deployed as broadly as it could be. So that's where I think agents could play a really meaningful role, like that super basic first line triage, the non-clinical stuff. Could they take that on and then really make sure you're getting connected to your care team when there's something that actually needs to be addressed, like a medication change or additional testing that's needed based on how your biometrics are looking. So I'm a big fan of your example, Mike. I think that's actually a really good one.
Thank you for that. I guess that does make me think, though, and you're pointing at something that we observed with printers, and that was that people said when printers came, we wouldn't need paper. Not printers. When computers came, we wouldn't need paper. But then everybody got a personal printer. And then for the longest time, probably 20 years out of my career, there was a lot more printing, way more printing than when you had to go to a shop to get printing done. Because you could just go home or sit in your office and click print. And if you wanted to carry something around before we had phones to carry it around, you'd print it out, take it with you read it on the train or whatever. And I think we're going to go through a phase like that. I don't know exactly what it's going to look like. But my concern, and it is a concern, that a risk that I've been thinking about, is that these agents are going to enable autonomous behavior in ways that we can't currently fully comprehend. But I think before they do that, they're going to drive a new kind of demand. And I thought of that as you were talking about this challenge with wearables and being able to have the remote patient monitoring staff to handle that we may actually say we're going to solve our provider problem by replacing it with like these co-pilot kind of utilities, but we may go through a growth phase where we actually need more providers in order to get to the next level. And that's something that I don't know that we're considering strongly. I'm not meaning to spring this on you or our audience, but it's something that came to mind as you were saying this. I don't know that we're considering that as strongly as we should be as a kind of a nation, and as we look at what the future brings. I certainly respect the drive that we currently have from the current administration for us to figure out how to use AI more effectively. I think there's great value in that. But I also do wonder if we won't experience kind of what I just described, and that in order to get over that hump to the promised land, we will actually need to pay the bill up front for some of this, I guess I'd say. Invest a little bit. And I'm not sure how that will happen, because as we all know, payment in healthcare is a big deal, and it definitely determines what you can and can't do. So that's an interesting thought. Sorry to throw that. Not asking you to solve it or for Ben to solve it. I'm just saying.
Mike's getting into the philosophy.
I am getting into the philosophy a bit. Sorry.
Well, it's good to hear an example of AI not taking people's jobs for once, Mike. Thank you for that.
No, I think it's gonna lead to new jobs, but it also may lead immediately to new demand in ways we are just becoming aware of. If my Holter monitor, like I had a phone number that would call me if they detected remotely something weird, they'd call me, "Hey, are you all right?" That could be replaced by the AI, right? That would actually be a where we wouldn't necessarily need as much of that. But then let's assume that I'm being monitored all across the board, and you're getting a more coherent picture of me Maybe it's not my heart that's the problem. Maybe it's something else that now you realize is going on. Now you need a different specialist to be paying attention. That specialist may need me to come in for visits. I myself might just be like, I got this new thing and I want you to be aware. They need to have a way of accepting that data. Like if my Apple Watch is monitoring my heart rate all the time, and I'm like, I think it's important that it's in here. How's that going to be done in a way that reimbursement is appropriate? Because ideas are infinite, I guess I'd say. Funding is not. And so we have to prioritize.
It's very true. And we have to remember, too, that providers and health systems, as much as we want to promote adoption of these tools, the ways that they're incentivized and supported financially look very similar, vis-a-vis like CPT coding, fee-for-service reimbursement, value-based care where it exists, but I don't think that pendulum swung as fast as we were all promised when we were in consulting together, Mike. That's still the paradigm that most providers are working with it. And so how do you incentivize transformation within that? I think CMS's access model is an attempt in that direction. That model is geared towards technology-enabled solutions. So, digital health companies, and not even ones that have a lot of, manpower behind them, but rather, kind of software-only solutions, and finding a path to reimbursement from CMS for some of those tools, which is great. But that model's not really designed for providers to avail themselves of that. And so when I sit down with our policymakers and our regulators, and we talk about what would providers need in order to adopt these tools, there's some common sense stuff that could be done within the existing system. For example, Dr. Kevin Schulman at Stanford has done some nice work thinking about where do we have CPT codes that are currently time-based codes, meaning the more time you spend on this activity, the more you get paid. And could we enable MDM or medical decision-making pathways for those codes as well? This was done for evaluation and management coding a number of years ago. These are your classic office visits. Those can now be billed either based on time or MDM. If we applied that same framework towards things like virtual check-ins, towards interprofessional consultations, you are no longer just incentivizing spending more time on the activity, and you could now benefit by making that service or interaction more efficient using AI. I think the bigger, broader philosophical question is a complex one, but I do think there's some things that we could do with the levers that we have today to not leave our, incumbent providers and our incumbent health system by the wayside, even as, private industry is developing all of this really exciting technology and deploying it in a very, direct to consumer, direct to employer type of fashion.
No, I love that. That's really great to hear. And I think we're going to have to go through a lot of transitional phases before we get to what people have begun to envision in healthcare and in general with AI. So definitely love that, hearing about the work that your team and that the team at Stanford is doing. That's great.
Mike, there was something else that you mentioned that really resonated with me, and what you were alluding to is this idea of, if you create all of this additional access to data, what do you actually have the bandwidth and the capability to respond to that signal? And that's something that we think about a lot as we consider which problems are we going to solve with digital health or AI. We really do take, a problems first approach, and there's so much that these solutions can do, but rather than be a hammer looking for a nail, what are the critical issues that we need to address as a health system? And so that's really the start of the strategy. The second piece around that is, the how. And at Stanford, Nigam Shah and the data science team there have done a fabulous job putting together something called the FIRM assessment, which folks can look up if they're interested. It stands for Fair, Usable, and Reliable AI Models, and helps us understand what is actually ready to develop and deploy. And then we need to understand the application and workflow layers, which we talked about, I think, earlier in the conversation, how those actually need to transform to make the solution successful. So we're not just putting tech out there and hoping it hits. And so I think that piece is often missing, and we should ask ourselves that when we're deciding which problems we want to solve. If we could get this data, would we be able to do something with it? Would we be able to respond? And then finally, I think there's this really interesting open question about how you monitor these tools and monitor the quality of these tools, because that in and of itself, requires bandwidth and methodology that I think as an industry we haven't fully responded to. But putting a model out there and not having a plan for how you're going to understand whether that model is delivering, functioning as expected. Having models that monitor models is something that we're starting to think about. These are all just fascinating, sort of balls in the air that we're going to have to figure out. But that piece that you said about, be choosy about the problems that you're going to solve and make sure that, if you put something out into the world, you've got a plan and bandwidth for how you're going to address it. It definitely resonates with how we're approaching these problems.
I'm tempted to say models all the way down, but I guess we're not there yet, but you're heading there is what you're saying.
So Leah, as a leader, we kind of discussed two different speeds of innovation today. I'd like to find out how you're managing these two speeds and balancing the long-term car building, if you will, with the immediate pressure of enhancing what is available to your team today. And then, also if you could follow up with where do you see the next orbit of digital care models in 2030? See what I did there, Mike?
I like it.
Ben's doing a great job as the host here, making sure we stay on target. So in terms of the two-speed organization, I think this ties in really nicely with the idea of how do you, both hold the tension between thinking of the future care model and solving the problems that we need to solve for today. I think that's a natural tension. I think it's one that is, healthy and should be held. You can't only be working, towards the future and not addressing the burning platform. And vice versa. If you only focus on those short-term goals, you're not going to be ready when the market moves and you need to transform your clinical organization. Maybe I can describe this by starting with an example about how we're applying that frame to an active initiative that we're doing at Stanford. And I'll start by telling you what's happening in market and then what's happening in the health system context. So this is around our virtual first partnership strategy. And I think one of the things that we've seen in the last couple of years with the rise of virtual care is that in some ways, care has actually become more fragmented because we've seen this huge lift in the number of virtual first provider groups that are out there. Typically, these folks are going directly to consumers, direct to employers, and offering, alternate virtual access channels. There was a massive influx of these digital health companies since the pandemic, and they run the gamut from, what's essentially vaporware to true, deeply qualified clinical teams and provider groups that just happen to be virtual and everything in between. So it's sorting through that mire is quite a challenge to understand, where should patients be receiving care as a consumer? Where would I want to go to receive care when everybody's got a good looking logo, an interesting company name, and a glossy slide deck? So that's a challenge in care fragmentation. When you go and you get care from an unintegrated digital solution, your primary medical home, your primary care provider, your specialist, whoever's typically taking care of you, has no idea that interaction ever occurred. That data doesn't always talk to each other. And so there's some risk there clinically, but also just to the experience for a patient to feel like they're the only glue that exists in their care. Now, the other side of that coin are the problems that health systems need to solve for, which is the access challenge, long queues in the ambulatory practices, capacity issues on the inpatient side. We don't have enough providers, specialists to be able to support everybody who needs care. So there's absolutely a role to play for high performing digital companies, in our opinion. So rather than have these sort of two streams running in parallel, or even worse, competing with each other, we really see this as an opportunity to partner, to leverage the experts that are within our health systems, especially I think academic medical centers are in a perfect position to do this, to vet the virtual providers that are out there, identify those that are clinically sound, are following evidence-based protocols, have really robust clinical teams, and a solid care experience, and actually integrate those with the traditional health system so we can create a more seamless experience for patients and actually promote those alternate access channels. So that idea of, how can you leverage partnership as an opportunity as compared to looking at private industry and seeing that as a competitor, a threat, I think is tremendous for the health system. And I think from an employer and a patient standpoint, it's a benefit to know that this group that you're accessing through your health plan or something that you've found on the internet is actually been vetted and recommended by your trusted care team and your specialists. So an example of where we've done this is in virtual behavioral health. At Stanford, we work with our psychiatrists. We vetted probably 30 different virtual behavioral health providers that were in market who are covered and enrolled with the insurance for patients that are in our market, whose clinical model mirrored what we would, care about and want to make sure our patients have access to at Stanford. And we actually created a collaboration with them through the electronic medical record and through interoperability to enable us to refer to those providers as seamlessly as we do to bricks and mortar providers that are in our network. And the closed loop referral is even better than if we were, working with a provider clinic that was, just up the road, because usually when we send a referral, we don't see anything back. When we do this type of interoperable connectivity, we can actually receive data back from the virtual provider and understand, did that patient schedule? How many sessions of therapy have they had? If we want and feel that clinical data is going to be valuable, we can start pulling some of that back in. And it's been a really successful collaboration. It's better for patients. They're getting access to care faster than they would otherwise. And they're having a really good experience with that, with the confidence of knowing, that their specialty team has vetted, the providers that they're going to. So we've seen through that program, PHQ-9 scores came down 30% in the population that has gone and worked with these providers. And importantly, the wait times for patients that were clinically appropriate to go to the virtual provider. It's not everyone, but for those who had an issue that could be managed there, their wait times went down from 66 days to 13 days. So that's just huge from an access standpoint. So long story, but I wanted to share that as an example of how you can solve a problem for today while thinking of the future care model, which is imagine a world where we have not just a network, and health systems have not just a network of bricks and mortar providers right around them, but an entire network of vetted, high quality virtual providers that they can integrate with. I think that's a future I'm really excited to see.
And if I could add just a moment, there are two things I wanted to note here that I think are very applicable to our earlier conversation about AI. One is that as we get into that future that we're talking about, then you could also be looking at vetting essentially, agent enabled or agent driven virtual providers. And the other is what you just talked about, the way that you're currently vetting, because there's going to be certainly that same continuum of people that are basically just a flashy smile and people who have really invested deeply into a model or a set of models that actually are evidence-based and have been vetted to the point that they're trustworthy. That kind of that same approach that you're taking today could be applicable to vetting those same potential future partnerships, and that the model that you're suggesting is like we don't need to throw away what we've spent at this point hundreds of years perfecting. Rather, we can join together in a hybrid that is that I think provides better value all around for the future. So I just wanted to kind of share those points because it was intriguing to hear how you were talking about that, and I was thinking about what we'd talked about previously.
Yeah, I can see we're both digital health optimists, Mike.
We are. That is exactly right.
Not that there's not a ton of really challenging problems to solve, but if you can see that future and what we can work towards, I really believe we're not so far off.
Right. And it's worth working through it when you can see that future. If you only see the problems, obviously, why are we doing this? But when you can see that once you get past those issues, there's real value and real change that takes place. And you gave examples of some that can take place right now with the work that you're doing with your virtual providers.
I share in the optimism, and Leah, I just wanted to thank you again for coming on and sharing some real world examples of things you're doing there at Stanford. I'll include links to your articles so our listeners can give those a read. And so, Leah, we've covered quite a bit today. We could bring it all back together and just give me your top 3 takeaways for our listeners.
For sure. This was fun. And thanks, Ben, Mike, for the conversation today. We did cover a lot of ground. And I guess I would say if there's 3 things that I would encourage, health system leaders, the listeners to take home today, one would be remember what care model transformation is and what it isn't. It's not the skeuomorphic transition of the current model into digital or AI enabled. It's actually reimagining the model itself. The second would be when it comes to innovation at the incumbent, look for opportunities to solve the problems of today while preparing for the model of the future. And then I think the third would be consider partnership. Our CEO, David Entwistle, likes to say, we can't build it all. We have to find a way to partner in order to meet the needs of healthcare and of our patients. So look for those opportunities, whether it's with industry, whether it's within policymakers, to think about how you could leverage the power of partnership to get where you're looking to go.
I just want to say thank you again for joining us on the Next Orbit podcast. This concludes our episode, and we'll see you on the next one.
The Next Orbit podcast requires more than a conversation. Be sure to subscribe, write a review, and share it with someone you think would benefit. Thanks for listening, and we'll see you on the next episode.